Hello everyone, welcome to the podcast. Today we will talk about bedside echo. We have the pleasure of hosting Wendy Finnie, a renowned echocardiographer and educator from New Zealand. Wendy has an illustrious career for over 30 years in the field of echocardiography and education. Wendy has trained hundreds of clinicians, both doctors and nurses, and echocardiographers in this technique of echocardiography. We are really excited to delve into the fascinating world of bedside echocardiography with Wendy Finnie. Welcome, Wendy, to the show. And thank you very much for taking your time. All right, Wendy, it has been a long time since we met last time, and I can still remember that there were so many scanning under your supervision that we did in New Zealand. Thank you for joining us. So the topic, as we have discussed earlier, we'll talk about bedside echo or focused cardiac ultrasound. And you are an expert on this topic. So first of all, Wendy, how do you define this bedside ultrasound for our viewers? If you can tell from your point of view, your experience, what is this bedside echo or bedside ultrasound? Please tell us a little bit more about it.
So bedside echo, it's not the same as what we do as echocardiographers. So it's using ultrasound to answer a specific clinical question and to assist with everything else that the clinicians are doing. So it's usually with a focused question. You're not doing a full echocardiogram, but you're picking up a probe with the aim to answer a question of what you think may be happening with your patient. And along with all the rest of your clinical skills. Excellent.
Yes. So that sometimes the other clinicians, sometimes when we talk about that I have done a bedside echo, they wonder, is it a formal echocardiogram or this is something else, or this is an ultrasound? So in my practice, when we talked about bedside echo, sometimes they use the term focused cardiac ultrasound. How do you find about this term, focused cardiac ultrasound, than the bedside echo? Do you feel that they're the same or they're different? Because in medical literature, sometimes we find this term more than the bedside echo. How do you feel about that?
It's probably not one that we use a lot in New Zealand, but it makes perfect sense because it is a focused scan. So it's what we talk about always when you're writing in your reports. How do you report it? Do you write a limited scan? Do you write a focused scan? How do you describe it? So it's probably quite a good term. I think it's quite a good way to describe it. It's not, we tend to talk about here in New Zealand either clinician-performed ultrasound or point-of-care ultrasound, but I think focused is good.
Yeah, I was looking at the in the PubMed. So they have got few bedside echo, but many articles, especially in the US, they use this term quite often.
Right.
And, I think that ultimately at the end of the day, this is the same thing, that we are trying to answer some dichotomous questions. That is there any pericardial effusion? How the left ventricle is doing? Is there any right ventricular strain pattern? Yes or no? Do we need to give some fluid? What is the fluid status? Yes or no? I can remember one of your webinar a few years ago, you talked about the 5 E's of emergency physicians. That was fantastic.
5 E's in echo, yes.
Yes, exactly. And I can still remember that. And in this 5 E's, one of them is the fluid status. So we look at the inferior vena cava, that is the entry of blood to the heart. And then we look at the aorta, that is the exit of blood from the heart. We look at the left ventricular function, that is ejection fraction. And we look at the pericardial effusion, especially cardiac tamponade. And last but not the least is what is the wall motion of equality or abnormality? What is the left ventricle doing? What is the right ventricle doing? And there is this brilliant article, which is very popular, the 5 E's of the emergency physicians. I really like this concept of the focused cardiac ultrasound or bedside ultrasound. So from your perspective, what do you find in case of the clinical applications of this bedside echo?
Yeah, so I think it's important that you're answering a specific question. And I think there's so many protocols, and the 5Es are just one way of doing it. So we all know about the rush protocols. The latest one that's coming out lately is the slice protocol, which of course includes the lung. I don't think it matters what you do so long as you have an order in which you do it. I think that's actually really important and a question. So you're picking up a probe, and is there a pericardial effusion? Yes, no. Is LV function severely impaired? Yes, no. Is there evidence of RV strain? So it's quite different to what I'm doing as an echocardiographer. You're picking up the probe with already a question in your mind. There may be a couple of questions, but I think that's the real clinical application, and you're using it with everything else that you've got in front of you as well, like the ECGs and whatever other imaging your patient may have.
Yes, exactly. So this is basically it's like almost like a physical examination, a part of the physical assessment tool that we use. And I know that you have got quite a few articles, and you talked about the application of ultrasound in rural medicine. How do you find in rural medical practice of this bedside echocardiography?
Oh, it's been a game changer for rural medicine, because a lot of these places, they certainly don't have X-ray after hours. They certainly don't have an on-site echocardiographer or sonographer. So for clinicians to have the skills to be able to answer some of these questions and has made a big difference in changing whether you admit a patient to hospital, whether you may transfer them by a different way. You may think that they were going to transfer by ambulance, do a scan and realize there's something more important. It may be in helicopter change. So because I do a lot of work in rural hospitals, it's absolutely vital for them, and it's fabulous. So good.
And I think it is not only New Zealand. I have worked in Australia in different small rural hospitals, and I can remember back home in the Indian subcontinent, the ultrasound, especially the echocardiography, that makes a huge difference. Currently, I'm doing a project with some paramedics, and they tell me that the bedside echo is so good, especially in the retrieval medicine. In a cardiac arrest scenario when there is no doctor, they can pick up so many important clues for the further assessment and management of the patients. That is fantastic. Yeah, carry on.
Oh, I think paramedics is a hugely growing group, actually.
Yes.
When I first started teaching point of care ultrasound, it was mostly for rural hospital doctors, which is where I was working. Now, our biggest group is emergency medicine doctors. Yes. But I think that the next lot coming that would be the most logical are the paramedics and the nurse practitioners, actually.
Yes, absolutely. And they are so enthusiastic to learn this technique and apply it in clinical practice. This is fantastic. So if somebody asks me that, why do we need this? Why do we need the bedside echo? I can give hundreds of examples, and I'm going to share a few examples here. So I was working in New Zealand in a rural hospital, and this lady came with shortness of breath and discomfort, lethargy. She's got a history of breast cancer, but she's under remission. Did not have any OBS, no vitals, no ECG. And with a part of the assessment, I did a bedside echo, and this is what I found. And this is amazing that this simple assessment tool helped me in rapidly taking a decision that this is a cardiac tamponade. We can see in this picture that the right ventricle and left atrium, they are collapsing. And there is a pericardial effusion here as well. This is one of those things that may make me very satisfied that a part of this, my clinical assessment, is bedside echo, and that makes a huge difference. This is another patient I saw in Australia, and again, coming with shortness of breath. And with this bedside echo, I straight away found that there is left ventricle is not working very well, and there is a bit of mitral regurgitation as well. And obviously, the patient need to come in, but also this picture, I can show the patient to demonstrate what is wrong with that patient. And also it helped me to convince my accepting clinicians that this is the patient's problem and this is the management protocol. And I've got a few more cases I can share here. So this was another patient on the left-hand side, septic patient, and we are thinking, should we give some fluid? This is a parasternal long axis view, and we can see that there is a hyperdynamic ventricle. And obviously the patient was tachycardic, we had to give some fluid, and we know that we have got a lot of rooms to give some fluid in this patient. And on the right-hand side here, this is a cardiac arrest scenario. And as we can see, there are a lot of clots in the right ventricle, and there is not much physical activity of the heart. So it is a very sad outcome, of course. But again, with this bedside echo helped us, all the clinicians, to take a decision. Should we continue or should we not? Because the outcome is not going to be very great. And I've got another case I can show you. This is a patient I saw a couple of years ago in Australia. Recent knee replacement and coming with shortness of breath. And this is a parasternal short axis view. And this is a beautiful D sign. The interventricular septum is flat. There is right ventricular strain. And the patient was stable. So we managed to do the CTP, and that showed that there's a large saddle embolus. And I know that long before doing the CTP that this patient has a saddle embolus. Very obvious. Do you like to add anything, Wendy?
Pardon?
Do you like to add anything about this?
Oh, I think that's entirely appropriate. That's exactly what you should be saying. And you're saying the point of care, clinicians are seeing way more PEs than what we ever saw in echocardiography, because by the time they got to us for formal scans, the right heart, which becomes abnormal very quickly, had normalized very quickly as well. So I find it quite scary how many PEs that we haven't actually seen before until clinicians were scanning.
Exactly. And this is another patient coming with shortness of breath and lethargy. And obviously there is pericardial effusion and right atrial and right ventricular collapse. So this is a cardiac tamponade who is needed to go to the theater for pericardiocentesis. And this happens so rapidly. And I can still remember that this bedside echo that I did on the patient within 15 minutes of arrival made a huge difference to the management. Now, Wendy, I know that everybody does this in a different way. Some people do it from the left side, some people do it on the right side. I'm going to share a few of my slides, and if you can jump in and talk us through how to do this bedside echo, that would be great. So a little bit of anatomy. This is the right atrium, right ventricle. This is the tricuspid valve, the left ventricle, left atrium. The mitral valve is there, and the aortic valve is behind. So we can look at the heart from the apex. We can look at the heart from the front. We can look at the heart from below and above. And most important thing I feel is that the best view that we can get can help us identify. And sometimes it can be quite challenging to get the best views. So the views that I do on the bedside and what Wendy taught us many years ago is obviously there is a subcostal view, there is the parasternal long axis view, parasternal short axis view, and in the apex, the apical views like apical 4-chamber view, 2-chamber view, 3-chamber view, 5-chamber view. There are different views. The most important view, I feel, that subcostal view, that is when I look at the heart from below. And in this case, I personally use the liver as my friend. I identify the liver and look at the liver, and then I look at the undersurface of the heart. And it gives us a lot of information. It gives us information about the pericardial effusion, the ventricular activity, the valvular function, and also the inferior vena cava. And in the inferior vena cava, we can look at if there is what is the fluid status, and most importantly, is it collapsible or not? During inspiration, normally it should collapse at least 50%, and during expiration, it dilates. Do you use any specific measurement? Can you talk us through what?
I pretty much never measure an IVC. I think when we first started teaching point of care ultrasound, we had the very specifics of measurements, and if it measured this much and it collapsed by this much, right atrial pressure measured 3 millimeters mercury. I think since then there's been an enormous amount of literature coming out saying that that's not particularly accurate. There's a lot of middling IVCs, and a lot of normal IVCs in a young, fit, well-hydrated person could be up to 3 centimeters. So I think rather than measuring it, I look at the big ones and I look at the small collapsed ones, and they're the ones that I think are clinically more relevant. I also think the subcostal view for clinicians is probably way more important than it is for me. I always do subcostal views in my formal scans, but I've already done all of the other scans as well. For you, you've often got an acute patient coming in, probably unwell, may not be able to move. You often have one chance to get a picture, and you can probably get enough information from the subcostal views often to answer your clinical question.
Exactly. So if the patient is unstable, we cannot put them in the left lateral position that echocardiographers do, and probably this is the best view, especially in peri-arrest scenarios. The other day I was talking to one of our paramedic colleague, and he does a lot of this bedside echo, and he said he never does it in a left lateral position. Always patient is lying on their back because they don't have the time. It is such a time critical emergency. They don't have the time to do that. And
yeah, everyone tells me that, and I do agree with that. But often, slight rolling will help if you can manage. If the patient can move at all, rolling slightly will help. That's a very nice image you've got there now.
Exactly. And this is another subcostal view. Again, we can see that this patient has got a big pericardial effusion, but what is more important is the right atrium is collapsing, right ventricle is collapsing. This is a single view that I can take that is enough for me to take a clinical decision. What do you think about that? So sometimes the clinicians ask me that, do I need to take all the views or just one view? And if it is just one view, which view do you recommend?
Oh, I think to answer your question here, that's entirely appropriate. You shouldn't be going on and taking all the rest of the pictures. You've got the answer to your clinical question. Is there a pericardial effusion or is there cardiac tamponade? Yes. If it was a grayer question, then look at other views. But no, there'd be no reason here to go on and look at other views.
I'm talking about as a whole, like in case of bedside echo, not about the pericardial effusion or particularly this patient. For any patient, do you recommend doing as many views as possible to get a good understanding, or do you suggest that whatever view you can get, one view is enough?
Oh, yeah, I'm not really a proponent of one view. I'm definitely, if your patient is stable, I think you'll get a lot more information if you can look at more than one view.
Exactly.
Particularly LV function.
Yes. My clinical practices, I try to do it as many views as I can, and some measurement as well. But obviously, if the patient is unstable, I just do 1 or 2 views. But most of the time when the patient is stable, like coming with chest pain and you are doing a bedside echo, try to do it as much as possible. That is what my practice is.
Yep. No, I agree with that.
So subcostal view is very easy to do. And do you have any suggestion if we don't get any good views, for example, in the emergency department or in the retrieval services? Sometimes the patient has a big meal, maybe big McDonald's, and there's a lot of gas in the stomach, and we don't get good views. Do you have any tricks or tips for the audience?
Yeah, if the patient's able to bend their knees up and relax their abdominal muscles, that certainly helps. That may depend how well they are. If they can take a big breath in, that certainly makes a big difference, but a lot of your patients are going to be short of breath. I think using the liver, like you talked about before, certainly help you. The ultrasound loves the liver, so if you can find a way to do that, that will certainly help. Yeah.
Yeah. And one of the challenge that sometimes I find is the obese people. Like, do you have any suggestion about obese people to get a good view?
Yeah, like
Challenge.
ultrasound's a challenge.
Yeah.
To be honest, sometimes the obese people can be easier to scan than skinny people. There is no rationale sometimes. I think that's what people find really frustrating when they learn to do ultrasound. They want very specific answers, and there often just isn't specific answers. So it's using whatever you can, and if your subcostal window is not working for you, then you need to move to another window.
Yeah, thank you. So another window is maybe the Plex view or parasternal long axis views, which is just on the left of the sternum in the third or fourth intercostal space. And the probe marker, the cardiology protocol is that probe marker is towards the right shoulder. And we can get multiple views here. So most of the time we do a section through the interventricular septum, and it looks like this. So for our viewers who are not familiar with this, this is the left atrium, the mitral valve, the left ventricle here, and then the interventricular septum, the right ventricle here, and then we have this is the right ventricle, and from the right ventricle above there will be the pulmonary artery coming up from there. So we can fan the ultrasound probe, and we can get a different views in different way. This is not the best view that I could get in this particular patient. I cannot see the aortic valve very well, but still I can get enough information from this view. I can see the left atrium, I can see the mitral valve, I can see the left ventricle, interventricular septum, the right ventricle here, and the aortic valve and ascending aorta here. One of the things sometimes I do, and pretty much routinely I do, is the EPSS. That is, I put the M-mode here at the tip of the anterior leaflet of the mitral valve. And in the M-mode, it will tell me how much movement it is having during systole and diastole, and what is the difference or distance between the interventricular septum and the tip of the mitral valve. And normally, if it should be less than 7 millimeter. If it is more than 10 millimeter, I get really worried. What are your thoughts about this parasternal long axis view and EPSS in particular, Wendy?
Us as echocardiographers, that's not really a measurement that we tend to do, but I know it's very much an emergency medicine measurement. I think it's a really useful thing to use if it helps you. I'm very much in favor of eyeballing and looking at the size of the chambers and the chambers' relationships to each other. Mm-hmm. The other thing that I often find is that I think clinicians are quite hard on themselves in their images. So often they will say this is not a very good view, but it's absolutely adequate to answer your clinical question. It's diagnostic. So I think you guys are often harder on yourselves than what we come along and look at them and think, yeah, that's okay. We can see what you need to see there.
Well done. Yeah, I do. I sometimes this is such a time critical conditions that whatever we get, and if it can help us to the decision making, I think that is good enough.
Yeah.
This is a different patient, and I put a color Doppler, and there is a bit of mitral regurgitation, and there is some aortic regurgitation as well. So that's very concerning. But if we look at the left ventricular function, that is squeezing very well, and there is quite a bit of thickening of the interventricular septum and the left ventricular wall, which is a good sign. But obviously, there is a valvular problem. I was talking about EPSS. This is what we do, especially in the emergency settings, because we don't have that expertise or time, or we don't have that type of training either to do that Simpson's method of measurement of left ventricular function or ejection fraction. But EPSS gives us some rough idea about the left ventricular function. So this is the left ventricular, this is the left ventricle, and this is the interventricular septum. The distance between the this is the E point, and this is the A point. The distance between these two, that is the EPSS. And as I've said, if the distance is less than 7 millimeter, we are happy. The ejection fraction is good. And if it is more than 10 millimeter, we get worried. The ejection fraction is pretty low. Okay. So this is another parasternal long axis view. I have shown this picture in just a few minutes ago. And this is the pericardial effusion with the right ventricular collapse and left ventricular collapse. Right ventricular collapse and left atrial collapse. There's a cardiac tamponade. And I had to call the cardiology quite promptly, and patient went to the cath lab for pericardiocentesis. I quite often do the parasternal short axis view as well, especially if I suspect that the patient might have a pulmonary embolism. One of the technique that I use it, and Wendy taught us the same technique, that just turn the probe 90 degrees with the probe marker directed towards the left shoulder with the aortic valve in the center, and that gives us a very good view of the aortic valve, or Mercedes-Benz sign. And this is the beautiful Mercedes-Benz. And this is the left atrium, interatrial septum, right atrium, tricuspid valve, and this is the right ventricle, the pulmonary valve. Sometimes we see the pulmonary artery, pulmonary trunk, right pulmonary artery, left pulmonary artery, and sometimes a bit of thrombus, especially if the patient is very unlucky. There may be a big pulmonary embolism there. So I often get this Mercedes-Benz sign very beautifully. Do you have any special technique to look at the pulmonary artery? Just fanning and bit of...
Fanning above the aortic valve level will help open up the pulmonary artery. Sometimes you can slip up an intercostal space. You may not see the left atrium as well, but that may open up the pulmonary artery a wee bit better, particularly if it's large. And someone who's had a PE, you'll be able to see it a lot easier. The Mercedes-Benz sign, look, often in a normal valve, you don't see it. So if the leaflets are thin and opening freely and you're not seeing them, there's no significant aortic stenosis, which is the answer to your question. Again, the machines that we tend to use are slightly higher spec machines, so we do tend to see it probably a little bit more often. But the point of care ultrasound machines now are just so much better. You would, from this view here, you're seeing thin leaflets. It doesn't matter if there's 2 or 3, there's no aortic stenosis.
Thank you. So if we now tilt the probe a little bit towards the apex, then we can get the fish mouth view. So this is the mitral valve, anterior leaflet, posterior leaflet, the left ventricle here, and the right ventricle with a thin wall here. Let me show a couple of clips here. Again, this is another real-life patient with a left ventricle, very nice and like a donut. And then we have got like a fish mouth opening and closing, and this is the right ventricle here. Do you have any tips for getting a better view? I sometimes find that the patient's lung comes to the field, and that obstructs part of this view, and sometimes pretty difficult to see like a complete left ventricle, like a circle. Sometimes I ask the patient to breathe out and hold it. It may not be possible all the time, especially if the patient is short of breath. But do you have any tips to get the best view of the left ventricle in the parasternal short axis window?
Yeah, often on that lateral wall, the patient, there's lung comes across when you're doing the scan. You can try held expiration. Of course, unfortunately, a lot of your patients who are wanting to be scanned are going to be short of breath and can't do held expiration. Usually, you fan through, you get a bit of lung, usually at about mitral valve level, but if you fan down to the pillary muscles, it sort of comes back into view again. So you kind of just got to work with that. I'm really obsessed with doing a proper scan from the aortic valve down through your mitral valve, so that you're seeing your mitral valve coming straight across and you've got wall muscle on both sides, because otherwise you can sort of create a D sign by being over-rotated with your probe.
Mhm.
And it's incredibly easy to do. And pretty much all of us, when we learn to scan, tend to over-rotate from our long axis view to our short axis view.
Mm.
So we can create any sort of D signs, regional wall motion abnormalities, just by being off axis. So I think it's really, really important to practice those scans, be aware. And it takes a while to see, A, that you're off axis, and B, to be able to know how to correct it.
Thank you. Thank you, Wendy. So this was the D sign we were talking about. So if the left ventricle interventricular septum, which is beautifully circular like a donut, but if there is right ventricular strain, sometimes the interventricular septum can be flat. One of the questions I get from my colleagues is, how do you differentiate between the acute and the chronic right ventricular strain? Like, for example, in a COPD patient, they can have right ventricular strain, pulmonary hypertension, for example. But again, if there's a peak PE, massive PE, acute PE, they can have the right ventricular strain as well. The other question is, what is the difference between the volume overload and the pressure overload? Do you have any suggestions, Wendy?
So if you've got right ventricular pressure overload, you'll have flattening of the interventricular septum and systole. If you've got right ventricular volume overload, you'll have flattening of the interventricular septum and diastole. And if it's in systole and diastole, you'll have it throughout the whole cardiac cycle.
Mm-hmm.
It's very hard to tell the difference between chronic and acute signs. And again, you've kind of got to put your echocardiographic features back into your clinical signs. So generally, a patient who has chronic right-sided pulmonary hypertension, and this is where people get a wee bit carried away. A D sign is a sign of pulmonary hypertension. It's not a sign of a PE. So if it's chronic, you're likely to have right ventricular hypertrophy. If it's acute, you're less likely to have right ventricular hypertrophy. But of course, you could have someone who has cor pulmonale and has an acute PE on top of that, and you cannot differentiate. So you have to use your other methods of scanning and of imaging and clinical skills to differentiate that. It can be difficult.
So I think that takes us to the basic question of bedside echo, that this is giving us some dichotomous answers to the questions. What is the clinical picture and what question we are trying to answer, and use the bedside echo to answer that particular question. Yes. And this is not like, is it a D sign or is it acute or chronic? It is, what is the clinical picture? Is a patient coming with hemoptysis and right leg swollen and coming with now shortness of breath, or the patient has got a COPD and having shortness of breath for 10 years. So it is like that. Yeah.
I think lung scanning has probably helped some of that as well, actually added on to your echoes as well, which of course we don't do as echocardiographers, but it would make a big difference.
So that is one of the important thing in case of the bedside echo that we do in the emergency department or in the point of care ultrasound field, that we are not doing only echocardiogram or bedside echo. We are incorporating it to the fast scan, the aorta scan, the lung scan, etc. And we look at the bigger picture rather than only what the heart is doing.
Yeah, I think you have a big advantage over us as echocardiographers and sonographers for exactly that. You've got the clinical component, the rest of the skills that you've got, and you're also using other skills which most of us don't use routinely.
Exactly, and we can do this at the bedside, and we can also intervene. We can do the management straight away.
Yeah,
I have seen sometimes patients who are sent from the echocardiogram lab to the ED because they found a cardiac tamponade. It has happened a few times.
Really?
Yeah.
Okay.
So the last view that we can talk about is the apical view. It can be a beautiful view and give us so much information if we can do it appropriately and get some really good views. So I usually try to do the parasternal short axis view and then identify where the apex is, and then I turn the probe in such a way that the probe is in long axis to the axis of the heart. And it gives me a very good apical four-chamber view. Of course, the probe marker is towards the left side or left shoulder. And we can get some views like this. So this is the heart once again. This is the right ventricle, right atrium, left ventricle, left atrium, and this is the aortic valve and the ascending aorta. And we can look at the left ventricle specifically, more on the right ventricle. Sometimes we can see the whole of the heart from this single view. And it looks like almost like this. So this is the apex, and this is the interventricular septum, interatrial septum, almost vertical. The left ventricle here, right ventricle, left atrium is here, mitral valve is here. The right atrium is here, tricuspid valve, and right ventricle with a lot of trabeculae carni. And that gives us a lot of information. Is there any big pericardial effusion, cardiac tamponade? It can give us information about the left ventricular function, right ventricular function. If we put the colored Doppler, it can give us information about the mitral valve, tricuspid valve. Thrombus, sometimes we can pick up. And of course, we can measure the left ventricular ejection fraction with the Simpson's technique. This is the patient. When I put the colored Doppler, I found a big, massive mitral regurgitation. And I believe there is some tricuspid regurgitation as well. Let me see if that shows here. Yeah, there is a massive tricuspid regurgitation as well. So it was very, very good for me in different ways. First of all, I could show the patient in front of them that this is your heart and this is the problem. And the poor guy told me that, well, I had the echo several times and my cardiologist never told me where the problem is. And this is, I feel that a big difference with this bedside echo application, that we can communicate with the patient and other clinicians better with this with the clips and the images that we take, rather than just verbally talking to them that you have got some leaky valve or something. And this is another patient with mitral regurgitation. Do you, as an echocardiographer, you do quite often the Simpson's technique, but do you have any advice or suggestion if we want to look at the left ventricular function, for example? Do you have any suggestion or any tips that we can use from the apical first chamber view, Wendy?
You've got to be really accurate to do the Simpson's biplane measurement. I do it routinely. You've got to be doing a lot of echoes to be able to do it. I tend to greatly discourage clinicians from doing it unless you're very experienced. I think certainly early on in your ultrasound journey, you're way better to eyeball. It doesn't really make much difference to you if the ejection fraction is 18% or 21%. It's severely impaired, and that's kind of answering your question. I think if you carry on and you're doing more ultrasound, then sure, by all means, you can start doing some of these measurements, but you really need very, very good imaging to be able to do the biplane accurately. And there's often patients that I scan where I may be able to get the apical four chamber, but I can't get the two good enough. So, and that's me as a very experienced echocardiographer. So it's quite a difficult technique.
I'm pretty sure you are familiar with this AI technique, especially some of the new ultrasound machines which are coming. As long as we can have some good views, the AI can do the measurement of the ejection fraction, which I find really amazing. That we don't have to go through all these different tracking and doing all these calculations. Just take take the picture and press that button, and it will give you the ejection fraction, which is fascinating.
It's quite scary almost, isn't it? It's AI, it's all different, but yeah, it still comes down to you've got to give them the right view. But if you can give it the good view, it looks like it's going to be pretty good.
Yes. How do you find with the correlation between the actual measurement from your clinical practice and the AI measurement?
I don't use it routinely, so I can't tell you too much about that. I'm only seeing it when clinicians are showing it to me, and it seems to be giving if the view's good, a reasonably good figure. But I haven't used it enough to be able to tell you too much about that.
Yeah, I think from our perspective, when we do the bedside echo, not a formal echo, this is the eyeballing that gives us enough information. Even if it does not give the exact number, it can give us some rough idea that the ejection is good or bad or ugly.
I think that's all you actually need, because that's going to send you whichever way you're going to treat your patient, to be honest.
Yes, exactly. So this is another of those examples of the apical four-chamber view, where more important than the heart itself, what is around the heart, which is a cardiac pericardial effusion and collapse of the right atrium, right ventricle. So this is sonographic cardiac tamponade. I can remember that one of the things you taught us in the past, that the cardiac tamponade is more of clinical diagnosis rather than sonographic diagnosis. Is it still the same, Wendy?
I still believe in that. I scanned a patient just the other week that looked very much like this echo you've got here. Perhaps not quite so much fluid. They were 6 weeks post cardiac surgery. They had COVID 2 weeks post cardiac surgery, and they came back in. I saw this echo. It had all the echocardiographic signs of cardiac tamponade. This patient was running up hills and had never felt better, and he was absolutely fine. And so it's always comes back down to how your patient is. I work in private practice, and I've had referrals come into me saying patient short of breath, query cardiac tamponade. Well, they're highly unlikely to be tamponade coming into a private practice. So I think we used to be really specific that it was a clinical diagnosis. I think it's slightly more grey now, but your patient is very sick if they're tamponade.
Thank you. And that brings us to that initial statement that the echocardiogram or point-of-care ultrasound, it's like a part of our assessment. It's like a stethoscope. One of the view that sometimes I do, not routinely, that is a suprasternal view. So when I put the probe just above the suprasternal notch, we can look at the arch of the aorta, and that gives us some very beautiful pictures. So one of the things that I really like is with the bedside echo and training and education over the last 15 years, it has been phenomenal, especially in the US, in Europe, and in New Zealand, in Australia. This is getting a big momentum. And we have seen that bedside echo has been incorporated as a mandatory part of the training in emergency medicine, in intensive care medicine, and not mandatory, but somewhat incorporated in rural health. In case of the anesthetists, they are very interested. A lot of GPs are doing echo these days, and of course the paramedics are doing it. So what is your take on the recent training from your experience, that over the last few years, how it has evolved in New Zealand, and how do you feel that we can take it forward or make it better?
So in New Zealand, we're getting a lot of, to our Otago University course, we're getting a lot of consultants coming along to do the course, because they need to teach their trainees how to do procedures using ultrasound. It's because the colleges are dictating this. I also think that the place for ultrasound to be taught is at med school, and people are doing anatomy. That would be the obvious place, and there's been some resistance, of course, for that to happen, but that would still be, you know, when the med students are doing anatomy, because if you get some of the med students in and you do some work with them, they just learn so quickly, and they're so enthusiastic, and they're learning all the anatomy. Often we're getting people coming back scanning, and they've forgotten a lot of anatomy. You've got to work through all of that as well, and it's hard. It's a hard skill to learn.
Exactly. From my personal experience, when I do the workshop in my hospital, I get a lot of medical students, and they are so much enthusiastic about this. Yep. When I run a course or workshop in different parts of Australia, I get the medical students as the volunteers and models, and they have got so much curiosity. And sometimes they ask, why don't we incorporate to the curriculum so that we can learn more about it from the beginning? And I'm in talk with one of the university to make ultrasound and bedside echo as well a part of the medical curriculum for the medical students. And I hope that over the next few years, we can actually be successful in doing that. And that will be a real game changer. I know that in the US, many of the medical schools, they made the ultrasound as a part of their training curriculum. And
yes, they have.
It is fantastic that from the medical school, they learn the knowledge, learn the physiology, the physics. And by the time they become a clinician, they can use it so well. And sometimes the old specialists get a bit frustrated that, oh, I don't know this. I was not taught.
Yeah. So, it's a fabulous skill to learn. And the time to be learning is when you're learning anatomy.
Exactly. One other thing we little bit touched base is the artificial intelligence, and there's a lot of development of ultrasound, especially the echocardiography, over the last few years. What is your take on it? How did you find from your experience how this has evolved, and how do you find it is heading towards?
Sorry, what was that? I'm sorry, I missed that.
The bedside echo, technologically, especially the incorporation of artificial intelligence and the handheld ultrasound devices.
Yeah, the handheld ultrasound devices are just so much better now. There's a lot of particularly good devices out there. The AI, again, I think it's going to be really interesting to see how it develops. It is going to develop, and it is going to make things easier. I think there'll be lots of changes in the coming years. I still talk to people with the handheld machines, and most of them who got very enthusiastic with the little handheld machines, if they're scanning a lot and there's a big machine with a trolley, they would still tend to go to that machine as opposed to their handheld ones. So it's going to be interesting to see what happens.
Yeah, thank you. A lot of research is going on this field of artificial intelligence, and it will be very interesting to see what happens over the next 5 or 10 years' time. But so far, I found that the artificial intelligence is making the life very easy for us. Whether it is the quantification of the left ventricular function or sometimes the identification of the anatomical structures, they are really good. But of course, there are challenges and limitations. That brings us to the next topic, Wendy. What do you find are the big challenges and limitations in the bedside echo?
Well, the biggest thing is the clinician's busy. It's something else that they're adding into their day. Their patients tend to be very unwell. They're not particularly prepared. They can't move. They're probably short of breath. So you're scanning much harder patients than what I'm scanning. And it's also, I think, you're trying to get an image, and if you don't get a good image, is it you're not getting a good image because you're not good enough, or is this as good as you're going to get on this patient? Which I think those of us who are scanning all the time, we know kind of fairly instinctively. You look around, this is the best that I'm going to get on this patient. So, And I think, again, like I said it earlier, I think you guys are quite hard on yourselves. I think often you get better images. They're still diagnostic. They may not be perfect. And, you know, when I'm teaching everyone, I want them to get nice images, obviously, but often you can get diagnostic images which aren't perfect, and you may not get all of the images, even though I encourage you to do so.
Thank you, Wendy. So yes, there are challenges, of course, but more we do it, I think we can get it better, and we can learn so much with our practice and review and discussion and collaboration. One of the thing I really like is the collaboration that what has happened over the last few years. Initially, it was mostly done by the cardiologists and echocardiographers, then the emergency physicians, the anesthetists. Nowadays, pretty much everybody does it. Even the GPs, I know that they do it with their little handheld device. And with a lot of research, a lot of collaboration, everybody is a winner, which is fantastic. What are your thoughts about this collaboration in case of the bedside echo, Wendy?
Oh, I think it's amazing. I think everyone's using it in a slightly different way that everyone can learn from other people. So someone like you in an emergency medicine, you'll see more cardiac tamponades. Someone working in general practice, their undifferentiated shortness of breath, whether it's a cardiac failure or an exacerbation of COPD, you know, everyone's using it a bit differently, but can also get the skills and collaborate with each other and help each other. And, you know, us as echocardiographers, we're learning how you use it, which is different to what we use it. Things like B lines, which we used to just think were annoying little flicky lines and coming across our picture, you know, it's very easy to know what they are now. So I think everyone helps each other and it's satisfying for everyone.
Exactly. And we can learn from each other. We can improve our skill sets. And at the end of the day, the patients are the winners because they are getting a lot of input from the bedside echo. And as long as that clinician has got some collaboration with other colleagues from their experience, and that is fantastic. So we talked about a little bit of artificial intelligence. What do you think is the future direction? Which direction we are heading to in terms of the application of bedside echo to our clinical practice?
Oh, I think it's going to become way and way more routine, actually. I think, you know, it's just going to be something that everybody's doing. As you said, you mentioned GPs. It's a lot harder for GPs. They have a lot more time constraints. You working emergency medicine, you're going to use it a little bit differently. Rural hospital doctors often have perhaps a little bit more time in their scanning, but I think AI is going to be a game changer. It'll be a wait and see, I think, really. It's a bit of an unknown.
Yes. And as the time is going, we notice that the machines are getting smaller and smaller, and they're getting more sophisticated, more informative, which is fantastic.
Quick boot up, easy to move around. Yep. With
regards to the patient experience, as we have said earlier, that at the end of the day, patients get the most benefit by the bedside echo. Over the last, I think, how many years? You have been working for 30 years or 40 now?
Yeah, I think 40 probably.
40, yeah. How did you find this has evolved from the point of view of the patient?
Patients love to be scanned.
Yes.
So, you know, particularly if you're lying in an ED and you're waiting on bloods to come back, your troponins to come back, so long as they're comfortable, I think they feel like something is happening with them. And I think you talked about earlier how, you know, you can sit there and you can show them the pictures and talk about it. I think it's a really positive thing for them. They feel like something's happening while they're waiting around for a lot of time. I probably only hear positive things from the patients, unless they're very, very unwell, obviously. But I think it's a fabulous thing for them, and that goes both ways.
Thank you. Yeah, my personal experience after application of bedside echo for my patient is that everybody is so happy. The patient is happy, their family is happy. They can, oh, that is my heart. Oh, that's my heart that is beating. Oh, that's fantastic. Yeah, they just love it.
Yeah, I agree.
So, Wendy, what are your advice for the clinicians or the medical practitioners, like an emergency medicine doctor like myself or my colleagues, for the bedside echo? Do you have any specific advice, any tips and tricks?
I think get some formal training. I think that's really important. I think it's a much harder skill to learn than what everyone thinks it's going to be until you start doing it. People are normally quite shocked about how much harder it is, you think you've got the views sorted on one patient, you move to the next patient and you can't get them because they're in a totally different place, totally different angles. I think those collaborations with peers and across the board, I think that's really important. I think if you work in a big hospital where you've got lots of people scanning, you're in a way better supportive position. But in a small hospital, a GP, or in a small rural hospital, pretty hard. So I think you need to make the effort yourself if you're going to be doing the scanning, is to try and get these relationships with people. It's like anything, the more you put into it, the more you will get out of it. It's a hard skill to learn. I mean, some of us have made a career out of doing it, so there has to be some skill to do it.
Exactly. Yeah, it's all about practice. But before that, you need to have some foundation, and that is what you talked about. Have some formal education, some training, and then you practice to make it.
And then you practice, because even once you finish that formal training, you'll know that you did a year working with us. You've still got to go and scan so much and regularly to keep up your skills. And
I'm still learning.
We all are.
Yes. All right. That brings us to the conclusion of this session. Thanks, Wendy, for taking your time. It was a great privilege and honor having you here. We learned a few important tips and tricks from you, and these are amazing. For you all, we will add some new link of the description. And also, I will add the link of Wendy's course that she's running in New Zealand, which is fantastic. And I hope that if you have any question, please feel free to ask, and you can write in the description section. And once again, Wendy, thank you very much for your time. And
thanks for inviting me along. I'm very passionate about ultrasound,
especially echocardiography.
Absolutely.
I hope that we can see you again in this podcast, and we'll learn some more skills from you. Thank you very much.
Thank you.
So if we summarize everything after the talk with Wendy, we can summarize that bedside echocardiogram is a fantastic tool in the assessment and management of the patients, especially in case of the time-critical emergencies. We can do the bedside echo with a few views. We can do a subcostal view to get a beautiful picture of the undersurface of the heart, the inferior vena cava. We can do the parasternal long axis and short axis views. We can do the apical 4-chamber view, apical 3-chamber view, and apical 2-chamber view as well. It does not matter if we get all the beautiful views. What matters is what is the clinical context? What is the question we are trying to answer? And most of the time, the bedside echocardiogram is a fantastic tool in giving us those dichotomous questions to be answered. And we can take some time-critical decisions. So there are a lot of references out there. We have got a lot of articles that we can go through. A few articles that I'm showing you here that I used for this presentation. And also there are a lot of relevant articles that you can go through. Now, if you have any questions, please drop me a line in the comment section below. If you liked the video, what you liked the most. If you did not like the video, what we could have done differently. We'd love to hear from you, and in the future we will try to make even better. If you have any questions, you can contact me through email, in the YouTube comment section, in my website, or in Twitter. Thank you very much, everyone, and I'll see you soon. Thank you. Bye for now.